I've been charged with talking about acetabular defects. We'll do this in an expedited manner. Just a quick survey here. How many of you would consider yourselves senior partners within your groups, by a show of hands? Okay. So this is my mnemonic for the types of patients that will commonly show up to the senior partners practice. This is in direct contrast to those that show up in my office, and here's my mnemonic: pus, obesity, opiate-dependent, and pelvic discontinuity. So in talking about acetabular defects, there are two classification systems, and for the sake of this talk, we'll be speaking about the Poprosky classification. There are type 1 defects, and these have an intact superior rim. There's no osteolysis of the ischium or inferiorly at the teardrop. Types 2A have mild superior bone loss. There's less than 3 centimeters of superior migration. There's a moderate amount of ischial osteolysis. And the critical thing here is that the dome is still supportive. Types 2B, supralateral rim defect of less than a third of the circumference. Types 2C, there's migration medial to Kohler's line, and again, the dome remains supportive. In Poprosky type 3A defects, there's severe superior bone loss, there's component migration of greater than 3 centimeters, severe ischial osteolysis, and really there's a lack of rim support for the implant. And finally, types 3B, these have severe superior and inferior destruction. There's a lack of rim support for the implant and a likely pelvic discontinuity. So what are our goals for reconstructing the acetabulum? It's threefold. Number one, to restore the hip mechanics, to find that center of rotation. Two, to reestablish the bony coverage of the new acetabular component. And number three is to achieve rigid fixation of both the acetabular component as well as any structural graft that you may use. So when we assess these patients preoperatively, we start with some imaging, and commonly we get an AP pelvis view. If we're concerned about the posterior and anterior columns, you can get Judeo-Blake views. In our practice, we will get CT scans with 3D reconstruction to assess severe defects to possibly prepare for a custom component. This allows us to identify the bone deficiency and to develop a plan for reconstruction. So let's talk about treatment. For type 1s that have small cavitary defects, you can essentially use uncemented hemispherical cups with screws. You can morselize bone graft these small cavitary defects. For type 2s, where you have segmental defects and you still have a supportive dome, you can still use a hemispherical cup with screws, grafting the small cavitary defects. You may consider utilizing structural allograft to restore bone stock. You can use porous metal augments, and you can also use oblong cups. For the surgical technique for reconstructing these type 2 defects, it's important to identify the true acetabulum. This allows you to work with the greatest bone volume, and you can use landmarks like the obturator foramen, the pubis, and the ischium to identify this. When you ream, you want to medialize to the inner table. This gets rid of small rim defects. Then you will expand ream at the true acetabulum until you reach the anterior and posterior columns. You can insert your trial and then assess your bone loss, and at this point in time, you need to decide whether or not to use structural allograft to graft the defect or to use a porous metal augment. If you decide to use the structural allograft, you can ream the defect to a hemispherical shape using small reamers. You ream down to a bleeding bed of cancellous bone. Then on the back table, you can prepare the structural allograft using these female reamers. And ideally, you want to have a graft that's roughly about 1 to 2 millimeters greater than the size of your defect. The graft can then be positioned in place and fixed either with K-wires or a bone tenaculum or even cancellous screws. If you have a major posterior wall or column deficiency, this can be augmented with a pelvic reconstruction plate that bridges the ilium with the ischium, and you can place screws through the graft into the host. You can then do your final reaming of the acetabulum with the allograft in place. You can insert your cup and place additional screws through the graft into the host bone. Here's a case of a 56-year-old female with severe rheumatoid arthritis on high doses of prednisone. She comes into the office with severe right groin pain, and using structural allograft to graft the medial defect, her acetabulum was restored with screws going through the graft into the host bone. Here's another patient, an 84-year-old female with a painful right hip. And in this case, porous metal augments were used medially to reconstruct the acetabular defect. These are pictures from Dave Llewellyn, who's done a lot of work with trabecular metal augments. And along with Arlen, they've shown that there have been good results short term. clinically and radiographically. For superior lateral segmental defects, sometimes you can get these isolated defects seen commonly in dysplastic revision total hips or acetabular fracture cases. And just for completeness, I'll mention that there are oblong cups available. You want to avoid using these if there's coexisting anterior and posterior column defects. With the advent of these porous metal augments, those have become more popular. Here's a case for my senior partner, Doug Dennis, using the oblong cup with nice restoration of that superior lateral defect. In type 3A defects, where you have severe superior bone loss and you have a lack of rim support for the implant, you can treat these with an uncemented hemispherical cup with screws. You may consider cheating the hip center higher. You may also consider utilizing structural allograft, porous metal augments, or perhaps a cage construct. Acetabular cages can be considered for these large segmental defects. You have two options, either a non-custom cage or a custom triflange. And these have been extensively written about. As you can see here, the results aren't overwhelming. There have been a significant percentage of failures in these cases, even at short to midterm follow-up. There are multiple failure modes of these cages. You can have loosening or graft collapse, late cage fracture, dislocation, and sciatic nerve injury. Dr. Gross has written about cup cage reconstruction, and this is where you place a porous metal cup against the host bone. You can then insert a cage over the porous metal cup and then cement a polyethylene liner. Here's a case of a 54-year-old female who had undergone 3 revisions prior to showing up to my office. And here's a cartoon schematic of placing an acetabular cup cage, placing the cup on the host bone itself with some bone graft, and placing the cage over the acetabular component. And here she is 3 years post-op with restoration of her acetabulum. For type 3B defects, where again you have superior and inferior destruction, lack of rim support, and likely pelvic discontinuity, you may consider using a cup cage construct or perhaps even a custom triflange cup. So custom triflange components can be developed preoperatively. You get a thin cut CT scan. There's a rapid prototype model that's created, and there's extensive correspondence back and forth with the manufacturing engineers to create a custom implant. Here's a pre-op CT scan showing a rapid prototype model. Here with these models, you can assess the bone loss. You can create the custom component, and typically we design these with 3 flanges. Lately, they've been adding locking screws, which have allow us to achieve excellent fixation both in the ilium as well as the ischium. And there are modular polyethylene liners that can be inserted. Here's a picture of a custom triflange cup. The clinical results have been written about by Doug Dennis. 26 revisions with a mean follow-up of 54 months and an 88.5% success rate, and 3 failures were in cases that all had pelvic discontinuities. And here's a picture of one of his cases with extensive bone grafting and a nice custom triflange cup that has restored the acetabulum. Here's a patient of mine with a painful left total arthroplasty. On her radiograph laterally, she's got a pelvic discontinuity, and here her acetabulum has been restored with a custom triflange cup and bone grafting. Here's that other patient, that rheumatoid arthritic patient, 56 years old now, addressing her left hip, and here restored with a custom triflange cup. In summary, there are defects that can be managed. Type 1s can be simply managed with uncemented cups with screws. Type 2, you can add structural allograft or porous metal augments to address the defects. Type 3s, you can consider a cup cage construct or a custom triflange cup. And if these options don't sound very appealing, you can always pass these off to your junior partner. Thanks.